The urinary system's macro anatomy doesn't have many components. The major organs are the kidneys. You have two of them. If you don't, it's okay. The one that's left will compensate for the other one. Your left kidney is slightly higher than your right kidney. The descending aorta comes right off of the heart and delivers blood to the kidneys. And then the blood returns via the renal vein, which dumps into the superior vena cava. However, waste products will be excreted through the ureters, not returning with the blood. There are two ureters, which connect each kidney to the bladder. The bladder is suspended. Here are two ureters there. The bladder is suspended by ligaments and primarily serves as a storage unit for urine. When you're ready, the urethra conducts urine to the outside. Blood enters the kidney, and you have to think it's kind of like a pathway, and blood has two choices. It can either return to the body through the renal vein, or the things in blood can be excreted through the ureters, bladder, and urethra. The urinary system employs a mucous membrane, or a membrane that's open to the outside, and therefore it must be kept moist. There are four mucous membranes of the body. We've already talked about digestive and respiratory. The urine and reproductive systems are combined into one urethral output in people displaying a long urethra. In people with shorter urethras, the output of the urinary system and the reproductive systems are not combined. The ureter, as seen in histological images, consists of epithelial tissue and a surrounding muscle layer, and an outer adventitia that connects to surrounding structures. Transitional epithelia, often confused with elastic connective tissue, it has these dome-shaped cells lining the lumen, whereas elastic connective tissue appears as squiggly lines in arteries and veins. The dome-shaped cells, they stretch when they're flattened. They stretch when the ureter expands. There are several tubules in your body that contain hollow, collapsed lumens, including the urethra, which is lined with stratified squamous epithelium, including the ductus deferens, which is covered in pseudostratified columnar epithelium with cilia, the uterine tube, which contains simple columnar ciliated epithelium, moves eggs along, and all of these epithelial differences will help you distinguish the tubes on any potential histology practical. The bladder itself is primarily a storage organ, and it contains these folds in here that are called rugae. We saw rugae in the stomach, and they're basically folds that just allow this organ to expand. And these rugae, they disappear when the bladder expands. The bottom portion of the bladder is like a funnel, and it funnels into the urethra, and this is an area called the trigone. There are ligaments that suspend the bladder. There is one big ligament up at the top, and then there are two transverse ligaments that hold the bladder into place. A cross section of the bladder reveals that it is lined with this transitional epithelium, which also allows for expansion. So there are some rugae in this low magnification that allow for expansion, but also these dome-shaped cells here also allow for expansion. On a histology practical, you can distinguish between the bladder and the ureter by noting that the ureter will appear as a tube, while the bladder appears as a larger structure and usually just a small crosscut. The bladder's dome-shaped cells are key indicators of transitional epithelium. That's the epithelium that stretches as the bladder fills. Beneath this epithelial layer is the detrusor muscle, which is the major smooth muscle of the bladder. It responds for bladder contraction and urine expulsion. and the detrusor muscle is controlled involuntarily. Descending through the bladder leads to the urethra, which can be quite long or quite short, depending on what organs are contained in the pelvic cavity. The urethra is lined with stratified squamous epithelium, especially near the surface, and urine samples typically contain sloughed off cells from this lining. There are mucus glands in the urethra that facilitate the movement of urine, whether in the digestive, respiratory, or urinary systems. Mucus glands always serve as a lubricating and moisturizing function. The urethral sphincters are composed of skeletal and smooth muscle, and they control the opening and closing of the urethra. Urinary tract infections can refer to infection in any part of the urinary system: kidneys, ureters, bladder, urethra. Most often, UTIs are bacterial, and most often people with shorter urethras have a greater tendency to pick up that bacteria and deliver it to the bladder. Urinary tract infections can be categorized as descending from the kidney or ascending to the kidney. These two words refer to the origin and the final destination of the urinary tract infection. In descending infections, the infection comes from the systemic blood supply, and it descends the ureters to the bladder and out the urethra. In an ascending urinary tract infection, which is way more common, pathogens enter through the urethra and travel up to the bladder, ureters, and kidney, creating an ascending pathway. The micturition reflex is both voluntarily and involuntarily controlled, and it occurs much like the defecation reflex. There are two urethral sphincters. There is an internal urethral sphincter made of smooth muscle and involuntarily controlled. There is also an external urethral sphincter, which is skeletal muscle, and it I have to be honest, it can be both involuntarily and voluntarily controlled. I know that that kind of violates some of the rules that we've set up, but it can be. This picture that I have here of this bladder is from somebody who has a prostate gland, which is strategically placed between these two sphincters. Micturition can be initiated in a few ways, but the primary sensory receptors for initiating it are baroreceptors embedded in the wall of the bladder. These baroreceptors sense the higher pressure being put upon the inflated wall of the bladder as it fills with more and more urine. There are also chemoreceptors in the most superior wall of the bladder, and they play a part in initiating micturition, saying, "Oh my gosh, I keep touching urine. I'm full, I'm full." The confusion comes from recognizing that your bladder is controlled by both parasympathetic and sympathetic fibers, and that the internal urethral sphincter is innervated with receptors that receive norepinephrine, but the external urethral sphincter is innervated with receptors that receive acetylcholine. So the micturition reflex is a carefully balanced act of exciting and inhibiting neurons that control the sphincters and the detrusor muscle. Instead of describing the reflex in full, because you have the sensory part of it, I think it's important to understand a certain class of drugs that are used to stop parasympathetic activity. These drugs are called anticholinergic drugs. So people suffering from overactive bladder could be suffering from too many contractions of the detrusor muscle, or maybe like the inability to contract one of the urethral sphincters. And this would create a situation in which urine would be leaving the bladder when you don't really want to. Taking an anticholinergic drug would stop the excitatory signals coming to the detrusor muscle and the sphincters by way of the pelvic nerve. and therefore it would stop the detrusor muscle from squeezing urine out of the bladder when you don't want it to. It would stop that external urethral sphincter from relaxing when you don't want it to. The micturition reflex is controlled by way of nerves arising from the sacral plexus and from those nerves that exit the spinal cord around T11, T12. There is some play with the pons from the brainstem as well. Spinal cord injuries in either of these places can yield issues with micturition. Some people are faced with overactive bladder and leakage, which is very common for aging women. Other people are faced with the inability to coordinate the micturition reflex and to initiate voiding their bladder. As I have personally found, that area of voiding bladders is not an area of a lot of research. And there are not many people that are actually faced with the inability to coordinate micturition. I found that much of the research in that area was on voiding related to prostate swelling and management. Uh, I feel like this is an area where there are more patients where we think. And I would love to have one of my students come back to me in later years and be like, I have changed the face of urological medicine and implemented these practices. And everything is better now.